welcome back to the channel. If you're new here, my name is Nosa. I'm a medical doctor in the UK and I make videos on medicine and lifestyle. Today's video, I thought I should take you guys on what a day is like in my life as a GP registrar working from home. This is a temporary arrangement. It's only because I'm currently isolating. I'm going to be back at work next week. But I thought it would be interesting to film what I get up to. Yeah, you guys come along. I am working 9 to 5 today and I've got about 14 patients to call / maybe have a video call if necessary. All the patients that are currently on my list, because the practice is aware I'm working from home, they haven't booked any patients they believe would need an examination or face-to-face. My practice currently uses e-consultations as well as many other practices in the UK. Basically, it involves patients going online to fill out like questions. For example, please describe your symptoms, how long they've had it for, just to report everything. And it's kind of made our job easier because before you speak to a patient now, you already got a brief history from them. We obviously have the elderly patients who struggle to go online to use e-consultation, so they're always welcome to call the phones of the practice to book an appointment with a doctor, which is usually initially a telephone appointment, and then the doctor can decide whether you need a face-to-face appointment. So the first thing I always want to make sure is that my phone has been set on private. Therefore, when I'm calling patients, they don't see my number and they can't call me back. Obviously, I like hearing from patients, but what can happen is if you leave your phone number on and a patient feels the need to call you back, and then it can be a bit inappropriate, especially if they've got your number saved on their phone, to just call whenever they want. So the first patient I just spoke to was a pregnant lady with symptoms of vaginal thrush. She was complaining of a few days history of white, thick, cottage-like discharge with intense itching. Now, vaginal thrush is pretty easy to treat, but when a woman is pregnant, the treatment is different versus if she wasn't pregnant. Thrush is quite common in pregnancy, and I believe it's because of the hormonal changes that happen during pregnancy. But anyway, it's pretty straightforward to treat. If the woman is not pregnant, I would be prescribing clotrimazole, which is an antifungal medication. It's a pessary, which is like a little tablet you insert into the vagina. I just usually prescribe 1 dose if the lady is not pregnant, and then I prescribe clotrimazole cream for the vulva area on the outside to help with the itching as well. But in this case, because this woman is pregnant and over 16, NICE guidance says that you should treat them with clotrimazole pessary, 1 pessary each day for 7 days. And I also prescribe the cream as well to help with the itching around the vulva area. Obviously, with any patient when I speak to in general practice, we've been told, and I've learned, is to safety net. We're making the best educated diagnosis and treating that. So I always tell patients, just in case there's that tiny chance I'm wrong, please, if your symptoms don't get better in the next few days, or if they get worse, please let us know. If I think it's an urgent situation, then I would say please call 111 or 999 out of hours, depending on the cause or depending on what the scenario is. For example, if it's chest pain, I would probably give that advice. The second patient I just spoke to was a man with a history of eczema. Eczema is, simply put, itchy, flaky, dry skin in the simplest terms. And he's recently had a flare-up. He sent me pictures. For confidentiality reasons, obviously I can't share those pictures with you guys, but I can obviously show you some similar pictures online of what eczema looks like. It just looks quite, flaky, dry skin. In terms of how we treat eczema, the most important thing with eczema treatment is actually emollients. So making sure the skin is very, very well moisturized. But in his case, he's been using emollients about 3 times a day. He's also bought over-the-counter hydrocortisone 1% cream, which is the mildest steroid you can get. And you don't have to get a prescription for it, actually. You can just go to the pharmacy and get hydrocortisone 1%. So he's tried that as well, and his eczema doesn't seem to be getting better. And he's come to us because he's looking for something stronger to help get rid of his eczema flare-up at the minute. There's a steroid ladder starting from the least potent steroid to the most potent steroid. And I have this rough mnemonic called HEBD, HEBD. H is for hydrocortisone, E is for Umovate, B is for Betnovate, and D is for Demovate. So in his case, because he's tried hydrocortisone, I'm going to go a step up, which would be Umovate. I'm going to try that out for a week. I'm going to safety net again, tell him if it doesn't get better in the next week or he finds it's getting worse, he should let us know, and then we can consider trying something stronger again. I'd obviously encourage him to keep moisturizing regularly and all of that. Another dermatology case. I feel like today's a rash day, and I find it's quite interesting. In GP land, I just have days where I'm just seeing like UTIs, and I have days where all the rashes come. I don't know what it is, but anyway, my next case was a toddler with honey colored crusting around their mouth, and mom says it's been spreading as well. They've had it for a few days, and she was hoping to get some advice on what she can use to treat it. She sends in some pictures, and the child is completely well. So I tell her this is a common condition known as impetigo. It's basically a bacterial infection around the mouth, and it can happen in other places as well. You find some kids that have it on the thigh and stuff, but it's basically when you have a bacterial infection in the skin, and you treat it with some antibiotics. In impetigo, most of the cases would respond very well to some topical, so cream antibiotics to apply around the mouth for about 7 days. We usually prescribe fusidic acid 2%, and that seems to work quite well. The child has to stay away from school until the lesions are dried and crusted over, or they've been on the antibiotics for about 48 hours. So that case was pretty straightforward. It was just a lady with a few days history of a red eye that's sticky, watering, and feels a bit sore. Her vision's intact, so there's no blurring or any problems with her vision. I thought she had conjunctivitis, which is, you know, an infection of the eye. It can be caused by viral or bacterial cause. In her case, I thought it was likely bacterial, although you can never know for sure. I did prescribe her some chloramphenicol eye drops for 7 days, which is an antibiotic eye drops. And I safety netted as well to let her know that, you know, if her vision becomes affected, if her eye is not improving, or basically if her symptoms are getting worse, just so she knows, she can always come back to us to let us know, so her treatment can be reviewed, or if it's out of hours, then she can always call 111 if needed. But yeah, again, you know, it's something I've gotten into the habit of doing now most of the time. I would say like 98% of cases need safety netting, and it's something as a GP registrar I've picked up every time. I'm like, if it doesn't get better, if it doesn't whatever, then please let us know. So yeah, after a few more cases, after a few more management plans, history taking, and all of that, so now it's time for my afternoon clinic. I've got less patients than in my morning clinic, but I'm just going to try and get through them as soon as I can. The patient I just spoke to was a lady who was referred for a transvaginal ultrasound scan a few days ago because she was having irregular periods and infrequent menstruation, basically. The ultrasound has come back showing polycystic ovaries, and based on that, I diagnosed her with polycystic ovarian syndrome. Just so you guys are aware, having polycystic ovaries on ultrasound does not translate to having polycystic ovarian syndrome. You actually need to fulfill 2 out of 3 following criteria to be diagnosed with polycystic ovarian syndrome. The first one is infrequent/no menstruation. Number 2 is biochemical or clinical signs of excessive androgens like excessive hair growth or excessive acne. The last criteria is having polycystic ovaries on ultrasound. So for example, if somebody had no other symptoms of polycystic ovarian syndrome, we even did some blood tests to check their testosterone and they were normal, then, you know, if it was just polycystic ovary on ultrasound, you would not say that person has polycystic ovarian syndrome. You simply say they've got polycystic ovaries. When it comes to managing polycystic ovarian syndrome, it really depends on what the patient's main complaint is about. This lady was actually particularly concerned about her acne. She wasn't interested in having kids anytime soon, so we agreed on combined birth control pill. She had no contraindications to having it, so we decided to start her on the combined pill and to help control her acne. And I would expect her to see, you know, some improvement in the next several weeks/months. Another call, another diagnosis. I just made the diagnosis of GORD, which stands for gastric esophageal reflux disease. It's basically when you have, you know, acid in the tummy regurgitating or flowing backwards to the esophagus and causing irritating symptoms like my patient complained of. For example, a metallic taste in the mouth, a sensation of a lump in the throat, heartburn, and sometimes some of them even present with a cough as well. So it's one of the, if someone's getting this persistent cough and you can't really figure out what it is, you've done all the investigations, sometimes it's actually GORD as well. NICE currently recommends 2 ways to manage suspected GORD. I tend to go for the easier option and the best option for the patient, because I feel like they can start treatment right away if it is indeed GORD. First thing I start off with is a PPI like lansoprazole, 30 milligrams once a day for the next 4 weeks. Lansoprazole can take a while to work, so I just try and tell patients, I encourage them to be patient with it for it to, you know, try and reduce the acid in the tummy. The other option you can do is to go ahead and test for Helicobacter pylori in the stool, but you know, before you send the sample or before you get the results back, you might as well just start the patient on medication to see if, you know, it's going to be beneficial or not. The important thing I always try and remember to do is to give lifestyle advice. There are things that are known to worsen that, you know, heartburn or GORD symptoms. For example, excessive caffeine intake in the form of coffee, tomatoes, chocolate, citrus stuff. So I just try and tell patients as well to try and avoid those things, or at least minimize it as much as they can to help with their symptoms. If someone does not find any improvement in their symptoms in 4 weeks, then I would, you know, consider testing them for H. pylori, perhaps switching them to another type of acid suppression therapy like H2 antagonists. Another diagnosis made, possible hypothyroidism. Thyroid is not functioning at the level it should. It's functioning below what we would expect, and therefore there's a low thyroid hormone in the blood, and subsequently that's causing this patient to feel cold a lot of the time, causing their weight gain and feeling very tired. And yeah, so I requested some blood tests for her. I'm guessing that's going to come back with a raised TSH and low T4, and if that's the case, then I can start her on some thyroxine medication to try and bring her thyroid hormones back to normal. Hypothyroidism is actually quite common, and they tend to be, when a patient says they've got all these symptoms, obviously my main differential would be hypothyroidism, but I also tend to ask about mood as well, because sometimes hypothyroidism and depression, they can have overlapping symptoms, especially when it comes to the mood and fatigue and so on. So I see a few more cases from a UTI for which nitrofurantoin antibiotics is usually the first choice for most people. I see anxiety and depression. That includes either counseling and or medication as well, depending on the patient's preference and severity of symptoms. I spoke to someone with ringworm as well, which I prescribed some miconazole 2% cream for. The list goes on, so it's been quite an interesting clinic today. And then at the end of clinic, I discussed with my educational supervisor about cases I found, you know, a bit challenging. If I absolutely don't know what to do during clinic time, I would call my supervisor or send them a message on Microsoft Teams to ask them a question, just to double check a plan before I go ahead and finalize the plan with the patient. On occasions I'm not sure. So yeah, I hope you guys found that video sort of interesting. It is a bit boring just vlogging from home, I think, but I just thought I should let you guys know what a day was like in my life as a GP registrar working from home. Basically, I'm sitting at the desk majority of the time, looking at different cases, talking to different patients, coming up with different plans. And yeah, I'll get up to go and eat occasionally and drink, try and stay hydrated, and you know, exercise when I can or whatever. But yeah, if you guys have any questions, let me know in the comments down below. And if you haven't subscribed to my channel, please consider subscribing. I would love to have you guys back for more videos. Thank you guys so much for watching.